those who missed it last year, we're going to try to do better. I'm here with a working computer, so that's already a start. Today, we're going to discuss thrombophilias and its propensity to clot. I appreciate everybody who's helped put this together and make it work, which is obviously Dr. Pappas and Zoe for just being really supportive and helping me with all this. That being said, we're going to look at our first case. Try to pay attention to the details that you think are important as to how long you're going to treat, what the purpose of your treatment is, how you're going to test. So it's testing, treatment, duration, prophylaxis. Those are the kind of concepts that you're trying to think about, and what is the important information that you're going to glean from each clinical scenario, and how you're going to use that information. So I'm just going to give you two clinical scenarios to start, and then later on we'll address them. A 33-year-old previously healthy man presented with sudden onset dyspnea and sharp right-sided chest pain. He had noted right leg edema and calf discomfort a week earlier. He denied recent trauma, surgery, or immobility. His mother had a history of postpartum deep vein thrombosis. On physical exam, he has tachycardia with a heart rate of 114, normotensive with blood pressure of 102/76, hypoxemic at 88% on room air. Contrast-enhanced chest compute tomography demonstrated bilateral segmental pulmonary embolism, right lower extremity venous ultrasound documented, then pop DVT. Case 2, a 78-year-old woman with hypertension and obesity developed left leg edema and pain 2 days after ORIF right hip fracture. On physical exam, the patient had severe edema, tenderness of the left lower leg and thigh. Left lower extremity ultrasound demonstrated left common femoral, distal femoral, and popliteal DVT. So here we go. Thrombophilias, the definition: a tendency or propensity to clot, thrombose. We have a constant need to achieve hemostasis, right? We don't want to bleed. And we also want to have that constant balance between bleeding and clotting so that it's well balanced. It's not just one or the other. They're both interacting constantly to get that perfect blend between vessels, coagulation protein, platelets, and fibrinolytic inhibitors. So we have hemostasis, which is the arrest of bleeding, and then we have the interaction of the endothelium, platelets, and plasma factors with this constant procoagulant and anticoagulant conditions interacting. When we have blood vessel injury, we have constriction, then aggregation of platelets, and then the coagulation cascade, with the end goal forming a stable hemostatic plug. So we have exposed endothelium here. So we have phospholipid exposure with tissue factors, calcium, grouping and adhesion of activated platelets and thrombin, leading to secretion, aggregation, contraction, and a primary hemostatic plug, upon which secondary hemostasis can take place. Secondary hemostasis, we look at this, and again, these are happening at the same time as is inhibitory factors and further coagulation. So it's a perfect balance, and the end product here of our cascade is forming an organized fibrin platelet mesh thrombus. So in our cell-based model of coagulation, again, exposed endothelium, and we start with tissue factors, calcium, and we have the initiation of the clot. Then we have amplification of our serine proteases. We have propagation of the clot, and finally termination of the clot, where we have fibrinogen into cross-linked fibrin encasing platelets and forming the plug. Our regulation from antithrombin 3, which is regulating our serine proteases, protein C and protein S, which are cofactors regulating factors 5A and 8A in a fibrinolytic system. And we can see here how thrombin is going to, how antithrombin is going to interact and downregulate thrombin, as well as the serine proteases and activated protein CS molecule interacting and forming inactive or downregulating 8A and 5A to inactive forms. Just backing up just a moment, because of course we have arterial disease and venous disease and thrombus of those. Arterial thrombus usually is speaking to high shear rates with platelet aggregates and thrombus associated with vascular abnormalities such as atherosclerosis, where venous thrombi, low shear rates, stasis, and red cells with fibrin strands. Thromboembolism, when we hear that terminology in arterial disease, we're talking about stroke, MI, cold leg. Venous, we're talking about pulmonary embolism, DVT. So we have Virchow's thrombosis model, which is, again, just another description of, we have a vessel wall injury, we have relatively slow flow, which is stasis, and then we have this hypercoagulability, the combination of those leading to thrombosis. So when we talk about injury to vessel walls, we're talking about inflammation, we're talking about trauma, we're talking about artificial surfaces, immune-mediated diseases, and atherosclerosis. When we're talking about abnormal blood flow, we're talking about decreased mobility, things like economy class syndrome on a plane. We're talking about malignancy and myeloproliferative diseases. And then, of course, we're talking about thrombophilias, many of which that we want to sort of clarify today what they are and what their significance is, are the hereditary thrombophilias, although these are not all just hereditary, they can be acquired. When we talk about thrombosis, we want to talk about the site of the coagulation defect, where we're going to find the thrombosis. And for the majority of the hereditary thrombophilias, they're predominantly venous thrombosis with anecdotal reports of arterial thrombosis, except for the antiphospholipid syndromes, which can be devastating and can be both arterial and venous. Protein C system, as we talked about, regulating 5A and 8A, protein C and protein S are vitamin K dependent proteins produced in the liver. Protein C activated by a thrombin thrombomodulin molecule on endothelial cells, protein S being a cofactor, and protein C and S destroy, downregulate 5A, 8A, forming inactive forms and further blocking coagulation. So when we have a thrombus, then downstream effect would be for protein C and protein S to have an anticoagulant effect, so that, again, we have that hemostasis, that balance of both clotting and anticoagulation. Here is an example of the mock-up of thrombus with activated protein C and protein S, destroying or downregulating factor 8 into 8A inactive. And for factor 5, it also does the same. However, unless factor 5 is mutated, which we'll hear later, and is resistant to protein CS, which we refer to as factor 5 Leiden. So the three abnormalities of the protein C system, think of them as a deficiency. So this is a loss of function, protein C, protein S. The mutation of factor 5 is gain of function. It's factor 5 is now mutated and is no longer resistant to protein CS. So protein C deficiency is autosomal dominant and mostly heterozygous. However, there's incomplete penetrance. So you have to have activity levels 50% of normal or less for clinical consequences. And in neonates, you can have rare severe homozygous finding of purpura fulminans, and there is an increased risk of venous thrombosis. Acquired protein C, again, made in the liver, can be chewed up by warfarin, chewed up by ongoing thrombosis, vitamin K deficiency, and liver disease. Makes sense, as well as the postoperative state. Protein S, cofactor to protein C, again, hepatocytes, megakaryocytes, endothelium, vitamin K dependent. One thing to be aware of for testing, 60% is bound to the C4 binding protein, which is inactive. So when you are going to be testing for this, we'll talk about that later, you want to make sure you're testing for your free protein S, and as well as the total, but the free is the important part with the ratio. Protein S deficiency, again, it can be autosomal dominant with incomplete penetrance and acquired liver disease, also renal disease, OCPs, and inflammatory bowel disease. The picture from many of these, when to suspect, the clinical picture, the patient, we gave those first two scenarios. And so we're always going to be thinking, is DVT something, when we have a DVT, does this person have any special risk? Why did this happen? And so here we have mesenteric venous occlusion. So unusual locations makes us think about hereditary thrombophilias. Young age associated with pregnancy, well, that sort of goes together. Strong familial history, low risk, triggers, or no risk, idiopathic. And one thing to know is warfarin-associated skin necrosis. Activated protein C resistance. This is a point mutation where we change our arginine 506 to a mutated factor V with a glutamine in that 506 position, rendering it resistant to a protein C. Again, important for testing, because that is one of the tests that we're going to do, is look at activated protein C resistance. And again, increased risk of venous thrombosis. And here's just a mock-up of showing you that the cleavage site has been mutated and is no longer susceptible to activated protein C. The way we test, as we just referred to, determining APPT, APTT, and the plasma before and after the addition of activated protein C. You can do a genetic assay. However, you have to start the other way. You need to have some communication, which I've already done, and I have a pre-printed thrombosis panel, which allows me to order the ones that my insurance and Quest will perform as my screening, and then they have secondary tests if the screenings are positive, but you have to make sure you have the correct test that you're asking for. If you just think you can write it out, they'll deny most of it. Antithrombin 3 deficiency, synthesis in the liver and endothelial cells, activated by binding to that heparin-like molecule. And again, it inhibits thrombin as well as the serine proteases. It's resistant to unfractionated heparin, and it's treated with low molecular weight heparin. Causes of decreased antithrombin: heparin therapy, DIC, again, chewing it up, nephrotic syndrome, hereditary deficiency, which can be a reduction in production or an abnormal molecule. And when we think about it clinically, we're again thinking of young age, idiopathic, low trigger, pregnancy, and massive or unusual locations. Prothrombin G mutation, again, this is a gain of function. It is a mutation where we're going to result in 30% higher prothrombin levels, and it is quite common, hereditary thrombophilia. It is considered low risk. Now we're going to go on to two other thrombophilias. Heparin-induced thrombophilia. There's a type 1 and a type 2. Some people don't like the idea that they're grouped together because type 1 is really a benign finding and is self-limited and does not require stopping heparin, where type 2 is an immune-mediated complex against the heparin platelet factor 4, PF4 complex, and results in serious arterial and venous thrombosis. It's about 3 to 5%, and it happens later on days 5 through 14 with a profound decrease. And you need to stop the heparin, and it needs to be treated with a direct thrombin inhibitor. And here are some pictures of this serious disease. And from what I understand, these type of antibody reactions similar to what we've seen with COVID. Here's another antibody disease, antiphospholipid syndrome. Again, this is not just having antiphospholipid in a blood panel. You have to have both clinical complications and laboratory findings. This is the most common hypercoagulable disorder. There is the idiopathic variety as well as acquired varieties, which we'll talk about. And again, you have thrombosis, again, massive, same thing, unusual age, pregnancy-related complications, and antibodies against phospholipids. which we'll get into a little bit more later. So we have an idiopathic variety as well as associated with infections, drug reactions, and lupus, immune-mediated diseases. It can be found commonly in a healthy donor. So again, not everybody is going to present. However, the combination of the clinical as well as these laboratory abnormalities, anti-cardiolipin antibodies, IgG, IgM, anti-beta-2 glycoprotein, IgG, IgM, and lupus anticoagulant, leading to dangerous vascular thromboses, arterial and venous, as well as unusual pregnancy morbidity. When you get into the bones of this, it's really sort of specific. It's 3 pregnancy losses less than 10 weeks with normal fetal genetics. So so it gets very specific when they drill down on it. But for right now, we can just go with this combination of findings. So we're going to test for lupus anticoagulant, anti-cardiolipin, and anti-beta-2 glycoprotein antibodies. Now, because this disease is can be a very dire disease, and the patient can be presenting with extreme illness, there might be testing early on, and therefore the testing can be the disease can impact the testing, and so, which we'll get into later, but we have to test on 2 separate occasions at least 12 weeks apart. So who do we suspect this in? Again, thrombosis in a young person with a strong family history, unusual sites, idiopathic or light trigger, unexplained spontaneous abortion, and massive thrombosis. So who to test for? This can be tricky, and this is part of what we started to talk about. We haven't gotten too far into it, but many patients will test positive when you're looking for it for one reason or another, and many patients will test negative. If they test negative, doesn't mean they don't have a hypercoagulable state. And if they test positive, what are you going to do with either one of those answers? How is that going to change your therapy? And that's really what this comes down to. Is it going to change, is testing going to change the length of treatment? Is testing going to change how you're going to prophylax them in the future? Those are the kind of things you need to think about as to why you're doing what you're doing, because it's quite expensive. Again, this is a light mock-up of the different testing you can have. Again, you need to really verify that with Quest or LabCorp, and it would be nice if I can share for whoever wants it, my pre-printed form for Quest. And if you use LabCorp most of the time, you could try to work with them to try to develop something similarly. The nicest part also is I get the pathologist gives me a consultation of the meaning of each test. So it actually sort of helps you learn a little. So who do we test? One take-home message is a strong risk factor: major trauma, major surgery, immobility, major illness. We do not need to test. Hang on just one second. Yeah, I'll be here for a while. I'm on a conference. Okay, going back. So we do not need to test for a strong provocation. Do we test at the time? We can test at the time of the event. In general, we don't want to do that, but we can test at the time of the event if there is a reason that we need to test, something that will change how we treat the patient. And of course, identifying goals of treatment. So let's think for a moment about a young woman who wants to go on oral contraceptives or wants to become pregnant. Those are reasons for thinking about why we might need to test, and test sooner or later, depending on that clinical scenario. So here it is. This is sort of simply done. That provoked trigger, there is no role for testing. However, weak triggers, unprovoked, unusual sites, strong family history, those are reasons to consider testing, and then think about how that's going to impact the patient that you have in front of you. And remember that a negative thrombophilia test does not exclude a thrombophilia. So it's not just the testing that's going to determine how you're going to either treat or prophylax the patient. That is just one component of the information in front of you. There aren't treatments for each of these thrombophilias other than treating the clot and then determining how you're going to treat the patient down the road. And again, just having an asymptomatic hypercoagulable state is not a reason to begin oral anticoagulation. However, it may be a reason, depending on what it is, to perform aggressive VTE prophylaxis in certain recurring scenarios, such as high-risk situations, including major and orthopedic surgery. Thank you. So now we're going to go back to some of the management of thrombophilias. So here we see that if you have 2 or more spontaneous or one life-threatening event, you're going to be treated indefinitely. Or if you have a extremely high-risk thrombophilia, and don't read, this slide isn't quite correct. Antiphospholipid antibody, paroxysmal nocturnal hemoglobinuria, and malignancies are reason for indefinite anticoagulation, as well as the one spontaneous life-threatening event or the 2 or more spontaneous events, indefinite. So those patients aren't really going to need prophylaxis because they've had a clot and they're going to be, or clots, and they're going to be indefinitely anticoagulated. Down at the bottom of the slide, we see this vigorous prophylaxis in high-risk settings. So those are patients that have one event with a minor trigger or just one event, maybe with a low-risk thrombophilia. So those patients aren't going to receive indefinite anticoagulation, but we're going to be very careful when they encounter additional risks. Okay. So in summarizing that, really we can look at this and say that a major risk factor, the recurrence is maybe 3%, whereas with a minor risk factor, the recurrence can be as high as 10%. So we have to be careful in those patients that were triggered either idiopathic or minor triggers, because they are at risk to recur, although they may not develop a spontaneous clot. We have to be aware of them having other triggers that they have to encounter, such as oral contraceptives or hormone replacement therapy. So a major transient risk factor, 3 months. I think everybody's aware of that. Down on the bottom of the slide, the risk goes way up. For the high-risk thrombophilias, again, antiphospholipid syndrome, paroxysmal nocturnal hemoglobinuria, and also we listed cancer here, and more than one idiopathic event, those patients are indefinite. It's the middle ground patients that are a little tricky, where we have one idiopathic event and or one minor risk factor, one idiopathic event or a minor risk factor. Now, how long are we going to treat them? Well, the first thing is the minor risk factor should be resolved, and then we can treat for 6 months and then strongly prophylax when encountering a problem, or a potential problem, I should say. All right, so this is going back to that case 1. Given the patient's youth, the family history of VTE, unprovoked event, thrombophilia testing was then performed and lupus anticoagulant was detected. Because a high-risk VTE recurrence in the setting of lupus anticoagulant in an unprovoked event, the patient was maintained indefinitely on warfarin. 1-year follow-up was doing well. Case 2. Given the patient's age, remember she was elderly, she had an ORIF for a hip fracture, she was treated for 6 months with warfarin until she was up, because it wasn't just the fracture and the surgery, it was also immobility. And so treated until that risk factor dissipated, and then she was taken off, and she's doing fine. No recurrence. Okay, now we're going to go through a handful of other scenarios and see what kind of other questions these bring up. A 35-year-old female is presenting to your clinic. Her father was hospitalized with DVT and PE, and was found to be heterozygote for factor V. She and her siblings tested and also heterozygote for factor V. She never had a VTE, and she uses condoms for birth control. How should she be managed? We have opportunities here with aspirin and warfarin and Xarelto and no anticoagulation. And the answer would be no anticoagulation at this time. In a person with an asymptomatic thrombophilia without a previous history of VTE, we recommend against long-term daily use of mechanical or pharmacological thromboprophylaxis. Why is that? Well, she wants to use condoms, so she's not going to be using oral contraceptives, so that's not going to add to risk. She doesn't want to get pregnant. That's not going to add to risk. So she's experiencing no added risk. And she's never had a clot. Again, she needs to know that she has this potential so that if she were to engage in something where there would be risk, she would need to be prophylaxed. But at this point, she's not. And we can look here at the annual incidence of clot, and we can see on the left-hand side that there is a risk of bleeding with oral anticoagulants. It's not a nothing. And the annual incidence for factor V heterozygote, this is listed a little high. It's not always listed that way. They're saying 0.06 or 6%. It can be as low as 3%. So you're really, you don't really gain a lot of benefit that's worthwhile in incorporating the risk of anticoagulation for someone who has factor V Leiden heterozygote. Section 2, or case 2, a 39-year-old female presents to your anticoagulation clinic, found to have prothrombin gene mutation, warfarin for 6 months with an idiopathic DVT. She's now asymptomatic. Her D-dimer is negative. What's your next step? So this is someone we've talked about with a low-risk thrombophilia. She had one idiopathic DVT, and she's been treated for 6 weeks, and now she's doing 6 months, and now she's doing great. What can we do? Do we continue indefinitely? A year, stop it and give aspirin, or just stop? And the answer would be we can just stop. We can just stop because I know the box is on the oral contraceptives and factor V, but it should be on the one above that, which is prothrombin gene mutation, has an annual incidence of 2%. Again, not enough to warrant ongoing treatment. And when we look at someone, now these are not asymptomatic patients who have never had a clot and just have a potential risk factor. These are patients who have had a clot, and we're looking at the recurrence rate for these low risk thrombophilia, and we find that idiopathic with a thrombophilia, idiopathic without a thrombophilia, there is no added risk with the thrombophilia for these low risk thrombophilia, and therefore they are not routinely treated indefinitely. Now on the bottom, you can see that cancer, antiphospholipid syndrome are listed as exceptions. And so when we look at the recurrent risk per year, we see that idiopathic with thrombophilia and without thrombophilia are roughly the same number. It is interesting that we're making a distinction that we don't need to treat those, even though the initial VTE, when it is provoked, their risk is only 1.8 for recurrence. So clearly that there is in idiopathic patients some increased risk, just not enough to treat. A 29-year-old female graduate student with no past medical history is presenting to your clinic. She states that she has several relatives with a history of blood clot and wants to be tested, and none of her relatives have been tested. She wants to start oral contraceptives for birth. For birth control, would you send off a workup? And my answer is a little different than this, because this one is that it's very complex and she should see a specialist. I think for initiating the oral contraceptives, she definitely needs to see her OB, perhaps a perinatologist, because they're going to have to pick the best drug for her. But to initiate the screening is perfectly reasonable to do it if you have a good panel and you can start the conversation, but you're not going to be the one ultimately taking care of her on her oral contraceptive. So at some point you're going to have to defer. One of the issues is that a positive family history, their patients are not really sure of the precise history. So the triggers, the risk factors that were involved at the time of those clots, whether they really venous clots or something else. Positive family history only has a 20% positive predictive value for thrombophilia, but that's not nothing. That's still 20%, and I think that beginning the conversation is still very reasonable with the initial testing. Now, we've dwelled a little bit, and this is a concept that the synergy of these diseases making things even worse than them separately. So when we look at oral contraceptives, and I've brought that up a couple of times, we've seen that when you have a factor V heterozygote, I've used the number of 3% with a 3 to 10-fold increase in relative risk. And if you're looking at oral contraceptives, 2 to 4-fold increase in relative risk. When you combine them, actually, it's not just the two. In addition, it leads to a 30 to 40-fold increase in risk. And so it can be quite substantial. Whereas the two individual, if you just were on oral contraceptives with no thrombophilia, or if you were just taking, or if you were just factor V, you wouldn't have to be on something. However, an oral contraceptive with factor V Leiden together is not is more dangerous or more risky, and actually would want to be managed differently. And that is why that's so important. You can look at some of these in combination. They really do change dramatically. Factor V Leiden with pregnancy, 35-fold increase. So, and with hormone replacement, 15-fold increase. So testing can be much more important in those scenarios. Okay, case 4. Which of the following conditions, if suspected, would lead to further workup? Paroxysmal nocturnal hemoglobinuria, antiphospholipid antibody syndrome, and malignancy. I've mentioned a VTE associated with surgery. I've mentioned these several times, so hopefully at this point you've got it. And yes, A, B, and C. Now, we talked about when to test, and we said that for strongly provoked clot, we don't need to test at all. And the timing of testing, if we think that that antiphospholipid syndrome, paroxysmal nocturnal hemoglobinuria, and malignancy are in play, we test right away, because these are very serious diseases, and we want to, and actually DOACs are not approved for treatment. This would be low molecular weight heparin. And so we would send these panels early on, but understand that the labs may be skewed. In the setting of acute VTE, anticardiolipin antibodies may be elevated, lupus anticoagulant may be prolonged, right? So that's why it's 2 separate tests, 12 weeks apart. And I've had this done incorrectly, not by me, but when I've received notes where someone has sent me someone in acute VTE with a decreased antithrombin level, and looking at it as if it was antithrombin 3 deficiency, which it wasn't. It was potentially just acute VTE. So we have to be aware that acute VTE, as well as heparin and warfarin treatment, will skew those results. But in the setting of something that can have life-threatening consequences, testing early is indicated. So a 30-year-old woman is presenting to the ED with acute dyspnea. Her exam shows multiple necrotic skin lesions. That can come up on a test because that is associated with what we're going to find here. Her CT is positive for multiple subsegmental PE. She's hemodynamically stable. What's the appropriate next step? We have several options here. Starting warfarin, starting low molecular weight heparin, beginning a hypercoagulable workup, starting low molecular weight heparin and deferring the workup until she's been off anticoagulation for several weeks. So if you're just talking about being off anticoagulation, it's 2 weeks for warfarin, 2 days for DOAC, and a day for heparin and low molecular weight heparin. And then beginning a hypercoagulable workup and decide which anticoagulant to treat, to use. And the answer in this case would be start the low molecular weight heparin. It's approved because skin necrosis is an indication that it could be antiphospholipid syndrome, and begin a hypercoagulable workup. And that's what is done. to make that diagnosis of antiphospholipid syndrome, yes, we have to see those laboratory abnormalities, but we also, because it can be somewhat common, we need to also have the clinical scenario of thrombosis, embolism, or recurrent pregnancy-related complications. And the findings are redemonstrated at 12 weeks. This is that same type of curve looking at recurrence rates and in patients with antiphospholipid. And we can see that the curves do not line up as they did before and cross, that there is a significant increased risk with antiphospholipid syndrome, recurrence as well as mortality. And so these patients will receive indefinite anticoagulation. So instances of lifelong anticoagulation, we're just going through that one more time. APLS with VTE, PNH, any second episode VTE, malignancy with the VTE, patients with life-threatening or unusual VTE. So our final set of cases, just to sort of go through this one last time and make some comments along the way. A 35-year-old female with no past medical history is referred to your clinic because a family member developed DVT during pregnancy. The patient wants to be tested for thrombophilia. She's found to be a carrier for factor V Leiden. She uses birth control. How should she, condoms for birth control? How should she be treated? Again, she's an asymptomatic patient with a heterozygote factor V Leiden, not homozygote, where there's markedly increased risk. She has mildly increased risk. It's not been shown to be of benefit to treat an asymptomatic patient with this low-risk thrombophilia. In patients with known thrombophilia other than APLS, but without a prior history of clotting, anticoagulation prophylaxis is not recommended. A 39-year-old patient with new DVT, antithrombin 3 deficiency. This is her second DVT in 2 years. So now she has a thrombophilia.
Hey,
she's idiopathic.
hey, Evan.
Yes?
Hey, this is Ken. Hey, these are fantastic cases. Could you also give your opinion on that same patient if you were to recommend ablations? If she came in and she needed ablations, would you still recommend no anticoagulation or prophylaxis for that same patient, for that first case?
I hear exactly what you're saying. And, you know, everybody's experience is different. If I know that someone has a thrombophilia, a primary relative, or a known history of DVT, I prophylax them on the day of the procedure.
Thank you.
I give them a one-time mini dose of Xarelto of 10 milligrams, and it's worked for me. It's not statistically shown. Peter will probably yell at me in a moment, but those are the big risk factors. The big risk factors are they have a known history of DVT, and they actually factor V Leiden would be the. But again, you're triggering them. You're giving them a reason to have a clot. It's not just a benign experience. They're having.
No, I agree with you. Yeah, no, I agree with you. I think that the recommendation, and you know, if they came in and you're not going to treat them, you're absolutely right. I would not recommend prophylaxis, but if you're going to do something, then that you're absolutely right. Right, the increased risk multiplies just like what you have indicated. So the 5 times risk for factor V is not going to be, 5 times. It's going to be 30 times because of the surgery or the procedure or some type of inciting event. And that's where I think you are right. I think you do have to prophylax these patients. And I'm not sure what everybody else's experience is.
Well, see, I'd also like to suggest, Evan, you talk about her using condoms. I think it's important to ask these people if they are using oral contraception, because I think if they've never had a clot, they have a first-degree relative, they're young, they're healthy, they're active, they're on contraception, and now you're going to do a procedure, you very definitely, I think, should prophylax them. So I think that's an important question that we need to ask young people.
Yeah, so we ask everybody those questions. And again, for primary relative, history of themselves having a clot or some disorder that's strong, they all get asked and they get prophylaxed at the time of the procedure because, yeah, and I actually did go to Xarelto and ask them if we could test this, and they said there's no money in Xarelto anymore. They're coming on board with a factor 11 inhibitor, and they said to reach out to them when that's starting to come out because they might be willing to do something with us, because venous lines are an issue all over the place. So venous procedures might be able to drive some small research money. I don't know if it would be enough, but there you have it. Okay, moving on. Is it okay if I move on, everybody? Okay, good. So her second DVT in 2 years. Again, at this point, she's going to be treated indefinitely, right? So we all know strong risk factor doesn't need to be treated indefinitely. Just the 3 months, perhaps, maybe longer, right? If the trigger is going on longer, like the woman with the fracture who's now still, at risk because she's not moving, she's immobile. So we look at the trigger that actually caused it, even though it was strong, for how long. So 3 months isn't fixed in stone, but the idea that she doesn't need lifelong, and then 2 or more life-threatening, those are reasons to go indefinite. And then those tweeners, the ones where it's been 1, maybe a low risk, or 1 with a weak trigger, but those patients have to be strongly prophylaxed to make sure that doesn't happen again. Next, okay, so we went through this one. And then this is a patient with a prothrombin gene mutation, warfarin for 6 months, now asymptomatic. And after 6 months, again, this is that same scenario where we can stop the warfarin because this is 6 months and she's now asymptomatic and doing well. And then last but not least, we're back to that original, which is malignancy. Now, I want to go over testing. So you have a patient that comes in, it's the first time you're seeing them, and they have a clot. What do? Right? They just walked in the door and they have a clot. So you're going to start treating them based on their clinical scenario, right? And you're going to decide, okay, this is worrisome to me. This is a young person, and there's no reason why she had a clot. I'm going to send off the panel that Quest has approved, right, that ahead of time, so you don't have a nightmare trying to get tests done and then everything's rejected and your insurance company allows it. And again, I'll send that out if everybody wants to see it. And you may do, you can't chase malignancies, it's difficult, but the patient may get a chest x-ray, maybe screen the stool, screen the bowel, simple things, breast, the basic screening malignancies, but you're not going to be able to chase every single one of them. You'll just be chasing your tail. But again, it's important that that patient, you sort of have a plan because they walk into all of our clinics, right? And I'm just saying, as the vein doctor, and saying, I'm going to find you a hematologist, I think is we shouldn't be doing anymore. And that's pretty much it, everybody. Oh, yep, there it is. That's our answer. Any questions?
No, so thank you, Evan. I mean, that was really, really good presentation, and I do hope that Stephanie will send out a link to the slide presentation, and for Sagar and for any of you studying for the ABVLM, I saw at least 5 to 10 test questions that pop up on the ABVLM exam all the time. So just for those of you who are taking the test, one of the things that comes up all the time is heparin-induced thrombocytopenia. And, they ask what the cause is. It's an antibody to the platelet factor 4. So that's one of the test questions. The other one that comes up is what are the thrombin inhibitors? So it's argatrovan and bivalirudin, but they ask what the loading dose is and what the maintenance dose is for the drips. So you should know that. I think the other thing that was very important is the discussion on the factor 5 heterozygotes. So even though they have a 7 times increased risk, it doesn't necessarily mean that you have to anticoagulate them for life. Those patients basically get treated like everybody else based upon their biologic behavior and whether or not they've had 1 or 2 unprovoked DVTs. So, and then the other thing that comes up is for a warfarin skin necrosis, they ask you questions about the mechanism of action. Why is it if you put somebody on warfarin, if you have a protein C deficiency, you are at higher risk for getting a skin necrosis? And then the other thing they ask you about is the location of that skin necrosis. And it happens to be in areas of high fat deposition. So you often see it in morbidly obese patients around the buttocks and in the abdomen. So anyway, like I said, I can go on and tell you other tests. There's at least 10 or 15 potential test questions for those of you who are going to be sitting for your ABVLM boards. So that was really, really good, Evan. That was, I think, out of the 3 or 4 times, that was your best one. So practice makes perfect. Anybody have any questions for Dr. Harris?
I had a quick question, Peter.
Sure.
We talked about risk factors. How about, whether it's time to do hypercoagulable prophylaxis? Someone has huge varicose veins and has either a superficial or a deep clot. Is just the presence of big varicose veins, since they're a risk factor, can you sort of write it off as that? Well, they had it because of that, so I don't have to do a hypercoagulable workup.
Evan, you want to answer that?
Well, SVT has been related to varicose veins. And so with SVT, I don't know if you'd have to do that. DVT is not as strong. I mean, it's one of the risk factors, but it's not as strong. So if you're having a patient with varicose veins showing up with DVT, I think if there's other compelling considerations, not just that one thing, but I think then you might consider that. Yeah.
Yeah, so I would say, David, from my review of the literature shows that one of the #1 risk factors for developing a DVT is a history of varicose veins, not just SVT. So absent any other risk factors, if you have a patient who's got large varicosities and you find a DVT in them and they don't have any other risk factors, I wouldn't engage in a hypercoagulable evaluation of those patients.
Okay, thank you.
Yeah. Anybody else? All right, thank you very much, Evan. Again, excellent presentation. Remember, when Stephanie sends out the presentation, there will be a link to the survey. You have to fill out the survey for CME credits at the end of the academic year. All right, have a good weekend, everyone.